Welcome to another video in pathology. In this section of cardiac pathology, we're going to discuss about restrictive cardiomyopathy. Introduction. Restrictive cardiomyopathy is a diastolic dysfunction that causes reduced diastolic filling and decreased ventricular compliance. Restrictive cardiomyopathy has distinct morphologic and hemodynamic characteristics that separate it from dilated and hypertrophic cardiomyopathies. These distinct characteristics are a non-dilated ventricle with typically normal wall thicknesses, ventricular walls that are rigid, resulting in severe diastolic dysfunction, and restrictive filling with elevated filling pressures and dilated atria. Generally, normal left ventricular systolic function is a feature of restrictive cardiomyopathy. Idiopathic or primary restrictive cardiomyopathy is an uncommon disorder that is manifested with these characteristic morphologic and physiologic changes in the absence of any identifiable cause. Epidemiology. It is the least common cardiomyopathy with a prevalence of 1 in 500. Etiology. Restrictive cardiomyopathy is most frequently caused by the following disorders. The most common cause is amyloidosis. It is caused due to buildup of abnormal amyloid proteins in the heart muscle. Sarcoidosis. Sarcoidosis is due to granulomatous inflammation of the myocardial tissue. Hemochromatosis. This disease occurs due to an abnormal iron deposition in the heart muscle. It can lead to either dilated cardiomyopathy or restrictive cardiomyopathy. More commonly, it causes dilated cardiomyopathy. Systemic sclerosis. This disease is caused by an abnormal growth of connective tissue that replaces myocardial tissue and causes diffuse thickening and hardening of the ventricular walls. Common secondary causes of restrictive cardiomyopathy often involve infiltration of the myocardium and include sarcoidosis, amyloidosis, systemic sclerosis, hemochromatosis, metastatic tumors, low-floor endocarditis, which is a form of restrictive cardiomyopathy that is associated with hypereosinophilic syndrome and accompanying myocardial eosinophilic infiltrates. Endocardial fibroelastosis is a rare condition characterized by diffuse thickening of the left ventricular endocardium due to proliferation of fibrous and elastic tissue. Most commonly, it occurs in the first 2 years of life. It can be primary with an unknown etiology or secondary, which can be associated with various congenital heart conditions such as aortic stenosis, aortic atresia, coarctation of the aorta, patent ductus arteriosus, etc. Iatrogenic causes of myocardial fibrosis such as chemotherapeutic agents like anthracyclines, alkylating agents, tyrosine kinase inhibitors, monoclonal antibodies like trastuzumab, radiation of the chest, and post-open heart surgery can all cause myocardial fibrosis. Pathophysiology. There is proliferation of the connective tissue, which decreases the elasticity of the myocardium, which in turn causes a decreased ventricular compliance. As a result, there is decreased diastolic filling, atrial congestion, atrial enlargement, and severe diastolic dysfunction, resulting in systemic venous congestion. Clinical findings. Clinical findings include progressive left and right-sided heart failure and a low-voltage EKG with diminished QRS amplitude. The most common clinical finding is dyspnea, and the symptoms of right heart failure can also be seen, such as jugular venous distension with a prominent Y descent, peripheral edema, ascites, hepatomegaly, Kussmaul sign, which is characterized by distension of the jugular veins during inspiration due to elevation of jugular venous pressure, and it can be seen in patients with constrictive pericarditis and restrictive cardiomyopathy, in patients with right ventricular infarction and tricuspid stenosis as well. In some of these patients, possibly S4 heart sound can also be audible. Diagnosis. The diagnosis of restrictive cardiomyopathy is commonly made using cardiac catheterization and echocardiography. Echocardiography is the best initial test as it can confirm restrictive cardiomyopathy. Echocardiographic findings. Signs of diastolic dysfunction can be seen, such as normal or decreased ventricular volume, rapid early but reduced diastolic filling, near normal or elevated ejection fraction, since ejection fraction is determined by the ratio of the stroke volume to the end diastolic volume, which are both decreased in restrictive cardiomyopathy. The ejection fraction is often normal. Atrial enlargement and dilation and valve thickening is also possible, which can be usually symmetric in these patients. Note that constrictive pericarditis and restrictive cardiomyopathy present similarly due to the fact that they both cause ventricular diastolic dysfunction. In contrast to hypertrophic cardiomyopathy, which features asymmetrical left ventricular hypertrophy, restrictive cardiomyopathy shows symmetrical left ventricular thickening. The following heart sounds can help differentiate between the two diseases. Patients with constrictive pericarditis can have a pericardial knock, which is an accentuated heart sound occurring slightly earlier than a third heart sound, which may be audible and rarely is palpable. Patients with restrictive cardiomyopathy usually tend to have S3 heart sound. EKG findings. There can be non-specific abnormalities in S and T waves. Low voltage is appreciated, especially in patients with restrictive cardiomyopathy secondary to amyloidosis. This is due to the amyloid deposition within the myocardial tissue, leading to a decrease in its electrical activity. There can be left bundle branch block and other conduction disorders in patients with infiltrative conditions involving conduction pathways. The treatment is generally limited and often only palliative, although novel therapeutic interventions are now made available to treat amyloidosis. Instead of treating the disease itself, focus on the treatment of underlying conditions, like performing a phlebotomy for patients with hemochromatosis, etc. Symptomatic treatment. The symptomatic treatment entails maintenance of sinus rhythm using beta blockers, increasing ventricular filling time, and decreasing the sympathetic activity with cardioselective calcium channel blockers, decreasing the preload using ACE inhibitors, with the exception of poorly tolerated ACE inhibitors in patients with amyloidosis, and for fluid overload using diuretics. Anticoagulation to prevent embolism in patients with a history of atrial fibrillation should be pursued. Heart transplantation in patients with refractory symptoms is the last option available. Here's an echocardiographic image of a patient with restrictive cardiomyopathy. Now, panel A demonstrates the left parasternal long axis view, and panel B is an apical four-chamber view, or simply put, the short axis view. The echocardiographic features typical of an idiopathic restrictive cardiomyopathy include a non-dilated, non-hypertrophied ventricle with dilated atria, Doppler in restrictive cardiomyopathy. The pulse wave Doppler in a patient with idiopathic restrictive cardiomyopathy demonstrates an increased E to A ratio with shortened deceleration time. Here's a schematic demonstrating how to differentiate between constrictive pericarditis and restrictive cardiomyopathy. Patients presenting with dyspnea or fatigue should be further evaluated in terms of their history, physical examination, a chest radiograph should be obtained, an EKG and a BNP should also be obtained. If all of these point towards a right-sided heart failure, this should be further evaluated with a Doppler echocardiography. If not, then evaluate for other etiologies. If the echocardiography shows evidence for constrictive pericarditis, the patient should be taken for pericardiectomy. If there is ambiguity in the diagnosis of constrictive pericarditis, then a CT scan or cardiac MRI should be pursued. And if either of those do show that the patient has constrictive pericarditis, the patient should be taken for pericardiectomy. And if there is still some ambiguity lingering around, then invasive hemodynamics should be pursued. And if that confirms that the patient has constrictive pericarditis, the patient should be taken for pericardiectomy. In all these three pursuits, if a diagnosis of constrictive pericarditis cannot be made, then the suspicion should be for restrictive cardiomyopathy. If restrictive cardiomyopathy is ruled out, then evaluate for other etiologies. If the suspicion for restrictive cardiomyopathy is high, or if it's possible, then consider biopsy. And on biopsy, if it's proven to be restrictive cardiomyopathy, then rule out infiltrative diseases, consider transplantation, and bridge therapy medically. Here are some of the pictures of dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. Let's compare them to see the major differences. In dilated cardiomyopathy, there is increased atrial chamber size, increased ventricular chamber size, and decreased muscle size. While in patients with hypertrophic cardiomyopathy, there is thickened interventricular septum, decreased ventricular size, and there is also accompanying left ventricular hypertrophy. In restrictive type, there is left ventricular hypertrophy.